Did you know that even with the most advanced surgery, a really significant number of hip socket fractures, particularly in our older patients, might still end up needing a total hip replacement? We're talking about injuries that don't just, break a bone. They fundamentally change a patient's mobility, their quality of life. It's this impact and the often quite counterintuitive complexities that we're here to unravel today. Welcome to the Depth Dive, the show where we aim to extract essential knowledge and hopefully some surprising insights from complex medical topics. Today, we're taking a deep dive into acetabular fractures, those critical breaks right in the hip's vital socket. These aren't just any fractures. They demand, well, a really nuanced understanding, meticulous decision making, and often highly specialized care. And joining us to unpack this intricate area, drawing from vast clinical experience and the latest research, is a true luminary in the field. He's a consultant orthopedic surgeon at the Royal London Hospital, specializing in pelvis, acetabular, and revision arthroplasty. He's also the founder of OrthoGlobe, an international collaborative dedicated to advancing musculoskeletal practice through global research. A very warm welcome.
Thank you very much for having me. It's a real pleasure to be here to talk about this.
It's our absolute privilege. So let's kick things off with a bit of a rapid fire segment just to set the stage for our deep dive. For those in our audience who might perhaps sometimes lump all hip or pelvic injuries together, what's the fundamental difference that really defines an acetabular fracture, and why is spotting that distinction so critical for outcomes?
That's a great question to start with. The fundamental distinction, and it really dictates everything that follows, is that an acetabular fracture inherently involves the articular surface of the hip joint, the cartilage.
The joint surface itself.
Exactly. Unlike many pelvic ring fractures, which might affect the structural integrity of the pelvis, but often spare the joint itself, an acetabular fracture directly impacts that smooth, cartilage-lined socket where the femoral head moves. And this direct involvement of the joint surface is absolutely paramount, because it's the primary determinant of post-traumatic osteoarthritis down the line. If that articular surface isn't restored, almost perfectly, the joint mechanics are disrupted. That leads to progressive wear and tear, pain, stiffness, and ultimately what we sometimes call the death of the hip, meaning it needs replacing.
So it really is all about that critical joint integrity, that surface smoothness, knowing that if we look at the bigger picture, epidemiologically speaking, who is most vulnerable to these injuries and what sort of forces are typically causing them?
Well, acetabular fractures show quite a fascinating bimodal distribution.
Right.
So we see peaks in two very distinct age groups.
Right.
In younger patients, typically those between, say, 20 and 39 years old, and this group actually made up over half the patients in one large study, these are overwhelmingly high-energy injuries. Road traffic accidents are a major cause, accounting for nearly 57% in that same study. You have to think of that classic dashboard injury,
Yeah.
where the knee hits the dashboard, driving the femoral head backwards forcefully into the acetabular socket.
Okay.
Then, in stark contrast, the other peak occurs in our elderly patients. Here, it's typically low-energy falls, often just from a standing height, that cause the fracture. And this is primarily due to weakened bone quality from osteoporosis. The precise force vector, the direction of the impact and the position of the femoral head at that exact moment, abduction, adduction, rotation, they're absolutely key in determining the specific fracture pattern we see.
It's quite remarkable how the mechanism shifts so dramatically with age. So finally, just to frame our discussion today, in a single sentence, what would you say is the biggest challenge you personally face when you're approaching the management of an acetabular fracture, particularly in our more senior patients?
In senior patients, I'd say the single biggest challenge is reliably achieving and crucially maintaining stable fixation in bone that's often highly comminuted, shattered into many pieces, and osteoporotic. And that task is compounded by their significant medical comorbidities, which ultimately impacts their ability to mobilize afterwards and recover effectively. It's a complex interplay.
That sets the stage perfectly for the complexity we're diving into. Let's really unpack the hip joint itself then. To genuinely grasp these fractures, we need to understand the architectural marvel that is the acetabulum. When you visualize the hip, what's the architectural blueprint that immediately comes to mind when considering these fractures? What are those critical anatomical elements a surgeon just has to understand?
Well, when I think of the hip joint, I immediately picture this beautifully engineered ball and socket system.
Yeah.
It's quite elegant, really.
Yes.
The ball is the femoral head, the top end of the thigh bone, and the socket is the acetabulum, which is an integral part of the pelvis itself. What makes the acetabulum so intricate and why injuring it is so challenging is its highly specific structural complexity. Both the femoral head and the acetabulum are covered with articular cartilage.
That smooth surface.
Exactly. This incredibly smooth, almost frictionless substance is absolutely critical. It allows the bones to glide effortlessly, facilitating movement without friction or pain. And surrounding this, you have strong ligaments, tough bands of tissue that provide stability whilst allowing an extensive range of motion without dislocation. But perhaps the most fundamental concept, particularly for surgical planning, is the Judet and littoral column theory. It's the bedrock of how we think about these fractures.
Right, the two columns.
Precisely. They conceptualize the acetabulum as being supported by two main columns, forming an inverted Y shape, almost like structural scaffolding holding the socket up. The anterior column is the more extensive one. It traces from the anterior iliac spines along the iliac wing and connects down to the pubic rami. The posterior column, in contrast, is a bit more limited structurally. It extends from the sciatic notch and runs down through the ischium. Understanding these columns is absolutely vital because fracture patterns aren't just random cracks. They typically involve breaks along or between these fundamental structural supports.
So the fractures follow these lines of force, essentially.
In a way, yes. And when we look at x-rays, we're not just glancing. We're meticulously searching for specific radiographic landmarks that help us delineate these columns and assess the fracture. Key among these are the iliopectineal line, which essentially represents the integrity of that anterior column, and the ilioischial line, which signifies the posterior column. You also look for the radiographic teardrop, indicating the medial wall, and the radiographic roof, that's the crucial weight-bearing dome. It's important to remember these lines aren't literal cracks themselves. They're overlapping condensations of cortical bone seen on the 2D image. But they offer critical clues about the underlying 3D structural integrity.
I see. And what about the surrounding structures? Nerves, blood vessels?
Yes. From a surgeon's perspective, perhaps nothing is more critical than the vascular and neurovascular considerations. There's a particularly precarious anastomosis, a connection between blood vessels often rather dramatically dubbed the corona mortis, the crown of death.
Oh, right.
This involves vessels from the external iliac system, like the inferior epigastric artery, and the internal iliac system, like the obturator vessels. This area is highly susceptible to injury during certain surgical approaches, particularly anterior ones. Significant bleeding can occur very quickly if it's damaged. And perhaps even more importantly, major nerves, most notably the sciatic nerve, pass perilously close to the posterior aspect of the hip socket.
So very close.
Extremely close. Damage to this nerve, either from the initial injury itself or, unfortunately, sometimes during surgery, can lead to significant long-term problems like foot drop. That's why we approach this region with such extreme caution and respect.
That paints such a clear picture of just how wonderfully complex but also quite vulnerable this structure is. So if the femoral head acts like a hammer, as you described earlier, how do these intricate architectural elements then dictate the distinct injury patterns we actually see? It sounds like even a small shift in force or femur position could lead to a vastly different fracture.
You've hit on a crucial point there. The pathophysiology is precisely that forces are transmitted through the femoral head, which really does act like a hammer striking the acetabulum. And the exact position of the femur at the moment of impact, whether it's adducted closer to the midline, abducted away from the midline, or rotated, and the precise direction of the force are absolutely critical in determining the specific fracture pattern and the amount of displacement. It's not random at all.
Can you give some examples?
Sure.
Yeah.
Let's take that common dashboard injury again. If the knee strikes the dashboard, it drives the femoral head directly backwards against the acetabulum. This frequently results in a posterior wall fracture. That's actually the most common pattern overall.
Right.
Falls directly onto the side of the hip. Transmitting force from the side can also cause these. And we differentiate fundamentally between high-energy trauma, typically seen in younger adults.
The road accidents, the major falls.
Exactly. Which not only causes significant bone fragmentation, but also extensive soft tissue damage, internal bleeding, and potential lacerations of major blood vessels or nerves. These patients often present with multiple associated injuries. That Jordan study again noted over half of 53.9% had other serious injuries needing attention: head, chest, abdomen.
A major trauma scenario.
Absolutely. In contrast, you have low-energy trauma, more common in our elderly patients. This causes fractures because the bone quality is severely weakened, primarily due to osteoporosis. Whilst the energy is lower, the compromised bone makes stable surgical fixation exponentially more challenging.
It's fascinating how the energy level ties into age and bone health. Given this wide spectrum, how do orthopedic professionals actually categorize these fractures? How do you standardize communication and, importantly, guide treatment decisions? Is there a sort of universal language?
Yes, there is, thankfully. To bring order and a common language to this complexity, the Judet-Letourneau classification is without doubt the most widely accepted and foundational system. It's really the framework we all use when discussing acetabular fractures. It systematically divides fractures into two main types: 5 elementary patterns and 5 associated patterns.
I'd say 5 of each.
Exactly. The 5 elementary patterns involve essentially a single main fracture line dividing the acetabulum. First, the posterior wall fracture. As we said, the most common overall, making up almost 38% of cases in the Jordan study, often linked to those dashboard injuries. Second, the posterior column fracture, involving that larger posterior structural support. Third, the anterior wall fracture. This is quite rare on its own. It often presents more as part of a complex pelvic ring injury or is associated with an anterior hip dislocation. Fourth, the anterior column fracture, involving the anterior support. And fifth, the transverse fracture. This is defined as a single fracture line that crosses both the anterior and posterior columns, essentially cutting the acetabulum in half horizontally.
Right, those are the elementary ones. What about the associated patterns?
The 5 associated patterns are combinations of these elementary types.
Hmm.
They indicate more complex and generally more severe injuries. You have anterior column with posterior hemitransverse, posterior column with posterior wall, transverse with posterior wall. Now, this one is actually the most common associated pattern, and importantly, it's linked to the highest incidence of sciatic nerve injury. That's a critical point for prognosis and patient counseling.
Definitely.
Then there's the T-shaped fracture. This is basically a transverse fracture combined with a vertical split that goes down through the quadrilateral surface in the acetabular fossa, creating that T shape on imaging. And finally, the both column fracture. This is where both the anterior and posterior columns are completely separated from the intact posterior part of the ilium. All the articular segments, the joint surface pieces, are detached. It's a truly severe injury pattern.
And are there specific signs you look for on imaging to help identify these patterns?
Absolutely. When we're diagnosing these, we're meticulously looking for specific diagnostic features or signs on the X-rays and CT scans that are almost pathognomonic, meaning if you see them, you know what you're dealing with. For instance, the gull sign. This is seen on the iliac oblique X-ray view, and it represents impaction, a crushing injury of the supramedial roof, the top part of the socket.
Okay.
It's a telltale sign often seen with posterior wall fractures, but critically, it's often a strong, poor prognostic indicator. It frequently suggests the need for an acute total hip replacement rather than just fixation because it signifies significant articular cartilage damage.
I see. So that sign carries a lot of weight.
It does. Another crucial sign is the spur sign, which is visible on the obturator oblique X-ray view. This looks like a sharp spike of intact ilium sticking out laterally, while the entire acetabulum is shifted medially. It's pathognomonic for both column fractures. It's also vital to understand the concept of secondary congruence, particularly in both column fractures.
You mentioned that earlier.
Yes. Despite the acetabulum being completely separated from the axial skeleton, the displaced fragments might deceptively appear to align reasonably well around the femoral head on initial X-rays. It can look falsely reassuring.
Yeah, so it looks okay, but it's actually completely detached.
Precisely. It can be profoundly misleading and really underscores the absolute necessity for more advanced imaging, like CT, to truly appreciate the extent of the injury and the instability. And whilst Judet-Letourneau remains the bedrock, we do sometimes briefly consider other systems, like the tile classification, which focuses on overall pelvic stability, type C being complex, unstable injuries, or the Young-Burgess classification, which looks at the mechanism of injury. But for the acetabulum specifically, Judet-Letourneau is really our guiding light.
That level of detail in classification truly highlights the precision needed. So after identifying the likely pattern, accurate diagnosis is paramount for planning treatment. What are the essential imaging tools you rely on, and what are those non-negotiable key findings you're looking for, especially given pitfalls like that secondary congruence?
For accurate diagnosis, we use a very specific, sort of stepwise approach to imaging. X-rays are always the initial step. While standard anteroposterior, or AP, views are useful baseline images, the critical views are the specific Judet views. We always get these.
A two oblique view.
Exactly. The obturator oblique view, which profiles the obturator foramen and gives a clear picture of the anterior column and the posterior wall. And the iliac oblique view, which profiles the iliac wing and clearly shows the posterior column and the anterior wall. These specialized views are absolutely essential for visualizing the fracture pattern properly and assessing the degree of displacement, which, as I said, is often not fully appreciated on a standard AP view alone.
Okay.
However, for truly precise management and preoperative planning, computed tomography, or CT scans, are unequivocally considered the gold standard. You really can't plan surgery properly without one.
Why is CT so crucial?
Well, a CT provides exquisitely detailed cross-sectional views of the hip. This is crucial for visualizing subtle injuries that might not be apparent on X-rays, particularly complex posterior injuries or impaction. It defines the fragment size, their exact orientation in 3D space, identifies any subtle marginal impaction, the crushing of the cancellous bone just beneath the articular surface, which affects prognosis, and it detects any intra-articular loose bodies, little bits of bone or cartilage floating in the joint, or articular gaps and step-offs. All of these are critical details for surgical decision-making. You'll simply miss these nuances without a CT.
And are there specific measurements you take on these scans?
Yes, we look at various things. For instance, we sometimes use measurements like the roof arc angle to try and assess stability. A fracture is generally considered stable if the main fracture line exits outside the primary weight-bearing dome of the acetabulum. This is typically defined as having an angle greater than 45 degrees on the AP and Judith views, or it's indicated by seeing an intact subchondral bone ring in the superior 10 millimeters on the axial CT cuts.
But you mentioned limitations.
Yes, it's crucial to note its limitation in certain fracture patterns, like both column fractures where the whole thing is detached, or some posterior wall fractures. In these cases, there isn't necessarily an intact portion of the acetabulum available for this type of measurement, so you rely on other signs of instability. Beyond static imaging, sometimes we need to dynamically assess stability, particularly for posterior wall fractures. This might involve an examination under anesthesia, or EUA, using fluoroscopy live X-ray.
To see how it moves under stress.
Exactly. During this, if the medial clear space, the gap between the femoral head and the socket, medially opens up under stress, that can be a definitive sign of instability in the posterior wall, which might not have been obvious from the static images alone. And finally, tying back to the urgency, if there's an associated hip dislocation, early imaging and diagnosis are absolutely critical because, as we'll discuss, these are surgical emergencies.
Right.
Reduction should ideally occur within 12 hours for improved outcomes, primarily to mitigate the risk of a vascular necrosis, death of the bone of the femoral head due to compromised blood supply. It's also vital to exclude an associated femoral neck fracture in cases of hip dislocation. If there's any doubt whatsoever on the initial X-rays, a CT scan is strongly recommended to rule this out, as finding one would significantly alter the immediate treatment plan, perhaps necessitating a different acute surgical approach altogether. It's clear these injuries demand a rapid, thorough, and incredibly precise diagnostic cascade. Professor, beyond the fracture itself, you've mentioned an associated hip dislocation can be a true orthopedic emergency. What's the immediate priority for a patient presenting like that, and what are the steps you take to manage it acutely? The immediate priority, unequivocally, is to recognize that a fractured acetabulum with a hip dislocation is a surgical emergency. It requires urgent reduction of the dislocated hip. This is not something that can wait. The clock starts ticking immediately to minimize the risk of complications, particularly that of vascular necrosis of the femoral head.
Okay, so time is critical.
Absolutely. Our initial patient assessment, of course, is always based on advanced trauma life support, or ATLS principles. That means we first prioritize airway, breathing, and circulation of the ABCs to ensure the patient is physiologically stable. Once that's secured, a thorough neurological and vascular assessment of the affected limb is crucial. We must meticulously check for any signs of nerve damage, particularly sciatic nerve injury, which can manifest as foot drop and inability to lift the foot even after the reduction. This assessment guides our immediate next steps and helps us anticipate potential long-term deficits.
And the reduction itself.
The process of urgent reduction is ideally performed immediately in the emergency department, or RESUS. It requires appropriate sedation, good muscle relaxation, which is key, and often a two-person technique to apply traction and countertraction safely and effectively. We commonly differentiate between the types of dislocation. Posterior dislocations are the most frequent, often seen with those dashboard injuries. The limb typically presents as shortened, adducted, and internally rotated.
And anterior.
Anterior dislocations are less common. The limb is typically externally rotated, abducted, and may be slightly flexed. The reduction maneuver is often considered slightly more straightforward due to the shallower anterior wall of the acetabulum, but they can still be challenging.
What if you can't reduce it closed?
If closed reduction fails in the emergency department, the implications are serious. The patient must be transferred immediately to the operating theater for an open reduction. This should ideally be performed by a hip surgeon familiar with the necessary approaches, often a posterior approach, and someone who is able to explore the sciatic nerve if there's any concern about entrapment or injury.
So specialist input is needed quickly.
Yes, it highlights the critical importance of having the right expertise available immediately, day or night. We also have to remember, as we noted from the Jordan study, that more than half, 53.9% of these patients have other significant body injuries.
Right, the polytrauma aspect.
Exactly. These can be life-threatening head injuries, chest trauma, abdominal bleeding, other fractures. They require urgent, simultaneous attention within a multidisciplinary trauma team setting. It's a comprehensive, coordinated approach that's vital for survival and optimal outcomes.
That immediate coordinated response is absolutely critical. But, Professor, it's equally important to clarify, as you hinted earlier, that not all acetabular fractures require immediate surgery. When is non-operative management a viable and perhaps even preferable option for these complex injuries? And what does true functional conservative care actually look like in practice? It's not just bed rest, is it?
No, absolutely not. That's a crucial distinction and a point I often emphasize, particularly when discussing elderly patients. Non-surgical treatment is a viable and often very appropriate option in specific scenarios. We consider it based on both the fracture characteristics and the broader patient factors.
Okay, so what fracture types might be suitable?
For fracture characteristics, we look for minimally displaced fractures, generally meaning the displacement is less than 2 millimeters on all views. Certain stable fractures, perhaps some isolated anterior column or anterior wall fractures, can also be managed non-operatively if the joint remains congruent. And crucially, some associated both column fractures can exhibit what we call secondary congruency. Remember that?
Yes, where it looks aligned despite being detached.
Exactly. Where despite the fragments being significantly displaced relative to the rest of the pelvis, they maintain a relatively stable articulation around the femoral head itself. In these select cases, even with significant displacement from the pelvic ring, the hip joint might still function acceptably without surgery, avoiding a major operation. Lastly, highly comminuted fractures, very shattered and severely osteoporotic bone, might also be better suited for conservative management. This is because attempting surgical fixation in such poor quality bone can be technically very difficult, unreliable, and prone to failure, potentially causing more harm than good.
And what about patient factors?
Patient factors are equally, if not more important, especially in the geriatric population. We strongly consider non-operative management for patients who are at a very high risk for surgical complications due to significant comorbidities, things like severe uncontrolled heart disease, advanced lung disease, poorly controlled diabetes, perhaps advanced dementia, or those with severely limited pre-injury mobility who simply may not tolerate extensive surgery and the demanding rehabilitation afterwards.
Makes sense.
Also, patients presenting late, say more than 3 weeks after the injury where the fracture has already started to stick or partially heal with fibrous tissue, may also be candidates. Delayed surgery in these cases can be exponentially more challenging and fraught with complications like infection or nerve injury. And finally, sometimes surgical factors play a role. If there's a lack of available multidisciplinary expertise locally to offer complex reconstructive surgery safely and effectively, then conservative management might indeed be the more prudent and ethical choice for that patient in that setting.
So if non-operative is chosen, what does that involve? Definitely not just lying in bed.
Absolutely not. Modern functional conservative treatment is far from passive bed rest. It demands a comprehensive, proactive, multidisciplinary team approach. This absolutely has to include specialist physiotherapists guiding early, safe movement, excellent nursing care focusing on skin integrity, nutrition, and comfort, dedicated pain management teams using multimodal analgesia, occupational therapists assisting with adaptations for daily living, orthogeriatricians who are utterly vital for managing comorbidities and optimizing the patient's overall medical health, nutritionists and robust community rehabilitation support teams for ongoing recovery after discharge. It takes a village.
It really does sound like a team effort. What are the key components?
Key components include meticulous pain management. Getting that right is fundamental. Correcting any fluid and electrolyte imbalances. Proactive pressure area, care to prevent devastating pressure sores. early chest physiotherapy to prevent pneumonia, and limb physiotherapy to maintain muscle strength and joint range. Early progression to sitting out of bed is crucial. And, of course, venous thromboembolism, or VTE, prophylaxis blood thinners, is critical throughout to prevent clots. But the cornerstone is early mobilization. Patients are actively encouraged to move as pain allows, often self-regulating their weight-bearing. We often find that elderly patients, in particular, frequently struggle with strict non-weight-bearing instructions due to other medical issues, perhaps upper limb weakness from arthritis or balance problems.
So you adapt.
We have to be pragmatic. Supervised ambulation with appropriate walking aids, like a Zimmer frame, is common and actively encouraged as soon as it's safe. All the while, we maintain constant clinical and radiological surveillance, usually with weekly x-rays initially, to watch for any late displacement that might change the plan.
And what about traction? Does that still have a role?
The role of prolonged skeletal traction has diminished significantly in modern management, especially for frail elderly patients. It has major disadvantages: pressure sores, muscle wasting, joint stiffness, risk of pin site infection, and the pins can easily disengage in porous osteoporotic bone. It might be used very short-term preoperatively, but not generally as a definitive long-term treatment anymore.
What does the evidence say about outcomes for this non-operative approach?
Well, perhaps surprisingly to some, studies have shown reasonably good functional outcomes in select elderly patients treated non-operatively, even for some fracture patterns that would typically meet operative criteria in younger, fitter individuals. What's truly interesting is that there's no convincing evidence when you adjust for comorbidities that conservative management inherently leads to higher mortality or higher reoperation rates compared to surgery in this specific elderly cohort.
That is interesting.
Yes, and secondary conversion rates to total hip arthroplasty, or THA, down the line are often quite similar for both conservatively and operatively treated patients in this age group. They might end up needing a hip replacement either way. Another fascinating point from a technical perspective is that performing a delayed primary arthroplasty, a planned hip replacement later on following a period of conservatively managed fracture healing, is often technically more straightforward than doing a secondary THA after a failed surgical fixation. This is primarily due to less scar tissue formation and no hardware interference from plates and screws that need removing. So this functional conservative approach really highlights a pragmatic, patient-centered philosophy when facing these complex challenges in our older population.
That's a truly crucial distinction from perhaps older, more restrictive ideas of conservative care. Now, shifting gears for fractures that are significantly displaced, unstable, and deemed suitable for surgery, open reduction internal fixation, or ORFF, remains a primary approach. Professor, what are the core goals when you undertake ORFF? What surgical techniques are involved? And crucially, what persistent challenges do you still face, especially in older patients?
When ORFS is the chosen path, our primary goals are threefold, and each is absolutely critical for the long-term survival and function of the patient's hip. First, we aim to meticulously restore a smooth, gliding hip surface. The joint needs to move without friction or catching to prevent premature wear and pain. Second, we strive to achieve an anatomical reduction. That means the bone fragments are pieced back together as perfectly as possible, with the goal being postoperative displacement, ideally less than 2 millimeters on follow-up imaging. That Jordan study reported achieving this level of reduction in about 84% of their surgically treated cases, which is good, but still leaves a significant minority with less than perfect reduction.
And the third goal?
The third goal is to provide robust, stable fixation with plates and screws. This is essential to hold the reduction while the bone heals, and importantly, to try and prevent or delay the onset of post-traumatic osteoarthritis, which unfortunately remains a significant long-term complication even after technically successful surgery.
Is there an ideal time to do the surgery?
Yes, the optimal timing for ORIFF is generally considered to be in the window between about 3 and 10 days post-injury.
Why that specific window?
Well, this allows some of the initial soft tissue swelling to subside, making the surgery technically easier and potentially reducing wound complications. But it's before significant bone resorption or fibrous tissue formation occurs at the fracture site, which can make achieving an anatomical reduction much more difficult. The fragments sort of get sticky and resistant to moving back into place. Delays beyond 10 days can certainly complicate reductions significantly, and delays exceeding 3 weeks can lead to substantial problems with both achieving reduction and maintaining stable fixation due to that progressive bone resorption and early callus formation.
How do you decide which surgical approach to use?
The surgical approach is chosen very carefully, based almost entirely on the specific fracture pattern identified on the CT scan. You tailor the approach to get the best access to the fractured columns that need fixing. For anterior approaches, we commonly use either the classic ilioinguinal approach or, increasingly, the modified Stapa approach, sometimes combined with a lateral window. The modified Stapa, in particular, is highlighted for giving excellent visualization of the anterior column and the medial wall, or quadrilateral plate, and it can even allow some access to the anterior aspect of the posterior column. It's particularly beneficial for buttressing comminuted medial wall fractures.
And for posterior fractures.
For posterior approaches, the workhorse is the Kocher-Langenbeck approach. This is commonly used for posterior wall and posterior column fractures. Occasionally, for very complex patterns like some both column fractures, a combination of approaches, perhaps anterior and posterior, might be necessary, but this significantly increases the operative time, blood loss, and overall morbidity for the patient, so we try to avoid it if possible.
Can you walk us through the basic surgical technique?
Sure. In terms of surgical techniques, the displaced bone fragments are first carefully repositioned, or reduced, back into their normal anatomical alignment, often using specialized clamps and instruments, all under fluoroscopic guidance, live X-ray checks. Then, metal plates, contoured to the bone shape, and screws are meticulously attached to the outer surfaces of the bone to hold the fragments securely while the fracture heals. In osteoporotic bone, there's a growing use of locking implants plates, where the screws lock into the plate itself at a fixed angle. This theoretically provides better fixation stability in weak bone, though comprehensive comparative evidence showing superior outcomes versus conventional plates is still somewhat limited, but emerging.
What about bone grafting?
Yes, that's often crucial. It's very important to consider bone grafting, using either autograft taken from the patient's own pelvis or perhaps cancellous bone substitutes to fill any underlying metaphyseal defects, particularly after elevating impacted articular fragments. If you lift up a depressed piece of joint surface, there's often a void underneath. Filling this void is critical for supporting the elevated fragments and preventing them from collapsing again under load during weight bearing.
Despite the best techniques, complications can still happen.
Oh, absolutely. Despite meticulous technique, potential intraoperative and early postoperative complications are significant and must always be anticipated and discussed with the patient. Sciatic nerve injury is a major risk, particularly with the Kocher-Langenbeck posterior approach. Reported rates are around 2–10%, and the Jordan study reported a 3.5% rate of iatrogenic injury, meaning caused by the surgery itself. This can lead to the functionally debilitating foot drop. Heterotopic ossification, or HO, that abnormal growth of bone in the soft tissues around the hip, is another significant concern. The highest incidence is seen with the older, more extensive approaches, though it seems to be lower with the ilioinguinal approach. We sometimes use prophylaxis, like radiation or medication, to try and prevent it in high-risk cases. There is also always a risk, albeit small, of damage to the blood supply of the femoral head during the surgery or from the initial injury, which could lead to that dreaded vascular necrosis later on.
Looking at the longer term, what are the outcomes and challenges of ORIF?
Well, looking at the outcomes and challenges, whilst the clinical outcome strongly correlates with the quality of the articular reduction, the closer you get it to anatomical. Generally, the better the result. A really significant proportion of patients, maybe up to 30% in some studies, and perhaps around 31% overall in others, still go on to develop post-traumatic arthritis, even with a good-looking X-ray initially.
So a good reduction doesn't guarantee success.
Unfortunately, not always. And this frequently leads to a high rate of late conversion to total hip arthroplasty, or THA. Some studies suggest 20–25% of elderly patients might need a revision surgery or conversion to a hip replacement within the first 1 to 2 years after their initial ORIF. We also know that the presence of that goal sign on the initial imaging, indicating severe dome impaction, is considered a very strong predictor of ORIF failure in geriatric acetabular fractures. Seeing that often prompts serious consideration for an acute THA from the outset rather than attempting ORIF.
And mortality.
It's also important to note that while the operative treatment itself doesn't necessarily increase or decrease mortality when you carefully account for comorbidities, high one-year mortality rates up to 25% in one study are reported in this elderly population undergoing surgery. This is often influenced by factors like age over 70 and their overall medical frailty, often measured by things like the Charlson Comorbidity Index. It truly underscores the vital importance of comprehensive medical optimization before, during, and after any major surgery in these vulnerable patients.
That's a truly comprehensive and, frankly, quite sobering look at the outcomes sometimes seen with traditional ORIF. Given these persistent challenges, particularly in patients with poor bone quality, you mentioned an alternative strategy has emerged, the fix and replace approach, or acute total hip arthroplasty. Professor, could you explain this concept and its specific role? When might you choose this?
Yes, the fix and replace strategy, or acute THA combined with fixation, represents a significant evolution in our thinking, particularly for managing these fractures in elderly or osteoporotic patients. The rationale is really to directly address those twin challenges we just discussed: the difficulty of achieving stable fixation in poor bone and the relatively high failure rates seen with ORIF alone in this group. At the same time, it aims to facilitate earlier weight-bearing and functional recovery, which is so crucial for older patients to avoid deconditioning.
So, fixing and replacing in one go.
Exactly. Instead of solely attempting to reconstruct the native joint, this approach combines fracture fixation, stabilizing the columns, with an immediate total hip arthroplasty during the same operation. There's some compelling data emerging. One study, for instance, highlighted its potential effectiveness, showing 100% hip joint survival, meaning no further surgery needed on the hip replacement with this combined approach, compared to just about 29% survival of the native hip after fixation alone in a comparable group.
That's a stark difference. So, when is it indicated? What are the triggers?
Well, the indications for fix and replace are still evolving, and there isn't universal consensus. But common factors that push us towards it include very complex judate-latournal fracture patterns, especially those involving both columns or significant combination of the weight-bearing dome. The presence of significant pre-existing hip osteoarthritis is a strong indicator. Associated femoral head or neck fractures often make reconstruction impossible. Any pathological fracture through tumor, significant cartilage damage seen either on imaging or at the time of surgery to either the femoral head or the acetabulum.
And patient factors.
Yes, poor bone quality, significant osteopenia or osteoporosis, where you anticipate fixation will be unreliable, is a major factor. Fractures deemed unreconstructible. Patients presenting after a prolonged hip dislocation where the femoral head might be damaged, or delayed presentations where the window for optimal ORIF has closed. Furthermore, several negative prognostic factors we discussed earlier, like age over 40 or certainly over 60, an anticipated pore reduction with more than 3 millimeters of residual displacement, multifragmentary fractures, very significant initial displacement of over 20 millimeters, or delayed surgery, particularly more than 5 days for associated patterns, or 15 days for elementary ones, all might steer the decision towards this combined procedure.
How is it done technically? Is it just like a standard hip replacement?
Not quite. It's significantly more complex. The primary principle technically is still to achieve stable osteosynthesis, stable fixation of the acetabular columns first, typically using plates and screws. For example, we might meticulously use 2 posterior column plates to achieve optimal rotational stability of the hemipelvis. This creates a robust, bony foundation onto which the acetabular prosthetic component, the cup, can be securely implanted.
So you fix the pelvis first, then put the cup in.
Essentially, yes. Modern practice often involves using highly porous acetabular components like trabecular metal or similar materials, which offer excellent biological fixation potential. These cups often have multiple screw options, allowing fixation into intact bone away from the fracture lines. Sometimes these cups can even be drilled through in strategic locations to place additional screws, for instance, placing an anterior column screw through the metal shell from a posterior approach to achieve a really strong triangular purchase that significantly enhances the fixation stability.
That sounds technically demanding. What about the surgical approach?
There's also been an evolution in surgical approaches for this. While older techniques might have involved complex constructs with intrapelvic wires and bulky anti-protrusion cages, modern strategies often favor using a single posterior approach, like the Kocher-Langenbeck. This allows the surgeon to both fix the crucial posterior column and wall fragments and then implant the arthroplasty components through the same incision. This potentially avoids the extensive soft tissue disruption and increased complication risks associated with needing dual anterior and posterior approaches. We might also use the patient's own femoral head bone graft after it's removed for the arthroplasty to pack and support posterior wall defects, helping to reconstruct the bone stock behind the cup.
It sounds effective, but complex. What about the downsides, the outcomes, and complications?
You're right to ask. While fix or replace can be highly effective in preserving hip function and allowing early mobilization, it is undeniably a major surgical insult, particularly for frail elderly patients. It's a bigger operation than either ORIF or a standard primary hip replacement alone. It typically involves significantly longer operative times, averaging around 3 hours, 174 minutes in one review, and substantially greater blood loss. averaging close to a liter, maybe 964 milliliters, compared to traditional ORAF.
And complication rates.
Reported complication rates are significant. They hover around 20% in some meta-analyses, but individual studies report rates ranging up to nearly 60%. These include infections, which are always a major concern with implants and extensive surgery, heterotopic ossification, although some studies surprisingly suggest lower rates of clinically significant HO with acute THA compared to delayed THA after ORIF, and aseptic loosening of the acetabular component over time, requiring revision surgery. The revision rate was about 2.3% in one systematic review over a medium-term follow-up of about 4.5 years. Dislocation rates can also be higher than standard THA.
What about mortality with this bigger operation?
Mortality rates are also a serious consideration. The mean reported rate is around 9%, but studies have shown rates up to 58% at 3 years in some very frail cohorts, with perhaps 26% mortality in the first year alone being reported in one challenging group. It's crucial to acknowledge that the high-level evidence base for acute THA, specifically for acetabular fractures, is still developing. This means that the surgeon's experience, judgment, and the specific capabilities of the treating center remain absolutely crucial in guiding these complex, high-stakes decisions. So it really requires a balanced perspective. While it may lead to better intermediate hip survival and function compared to ORIAF alone in selected elderly patients, the decision for fix and replace must be very carefully weighed against these significant upfront risks and the potential alternative of a simpler, delayed THA after a period of functional conservative management, especially for the most comminuted, difficult fractures in the frailest patients.
That's a truly comprehensive and, again, quite a nuanced look at the fix and replace strategy and the critical decision-making involved. Beyond the immediate treatment strategy, Professor, what truly dictates a patient's long-term journey? What factors determine the ultimate survival of their native hip after an acetabular fracture? You use that phrase, death of the hip. What predicts that?
This really gets to the heart of the long-term impact of these injuries. We use that concept of death of the hip essentially as the ultimate need for a total hip replacement, sometimes many years after the initial injury and fixation. Several key prognostic indicators truly dictate this long-term journey and determine if that native hip can be preserved or if it's destined for replacement.
What's the most significant factor?
The strongest predictor of poor outcomes, unequivocally, is age. Older patients, especially those over 60, or perhaps even over 40, according to some research, are significantly more likely to have fragile osteoporotic bone, experience higher rates of surgical and medical complications, and ultimately have a greater chance of requiring a THA. Their physiological reserve is simply lower, making recovery more arduous, and achieving lasting stable fixation is inherently more difficult.
And after age.
Another paramount factor is the quality of the articular reduction achieved at the time of surgery, if surgery is performed. An imperfect reduction, clinically defined as postoperative displacement persisting at greater than 2 millimeters, significantly increases the risk of developing post-traumatic arthritis. If that smooth joint surface isn't perfectly realigned, even by a millimeter or two, it inevitably sets the stage for accelerated wear and tear, leading to progressive pain, stiffness, and joint destruction.
Does the fracture pattern itself matter long-term?
Yes, specific fracture patterns and their initial severity also play a major role. For example, posterior wall fractures, despite sometimes appearing relatively simple on initial assessment, often carry a surprisingly poor long-term prognosis. This is often due to associated complications like subtle marginal impaction, higher risk of sciatic nerve injury, heterotopic ossification, and a propensity for secondary osteoarthritis development. Similarly, the more complex patterns like transverse and T-type fractures and the associated both column fractures often present higher risks just given their inherent instability and the sheer extent of disruption to the joint architecture.
What about damage to other structures?
Absolutely. Associated injuries are critical prognostic indicators. This includes any direct damage to the femoral head cartilage itself, sustained during the initial injury or dislocation. Significant marginal impaction, that crushing of the cancellous bone under the articular surface, especially in the weight-bearing dome, is a bad sign. Any pre-existing arthritis in the hip joint obviously worsens the prognosis. And other major systemic injuries, like head or chest trauma, can significantly complicate the overall recovery trajectory and impact the functional outcome. And that Siegel sign we discussed earlier, visible on imaging and indicative of severe dome impaction, is a particularly strong poor prognostic sign. Seeing that often immediately suggests that attempting to save the native joint with ORIF is likely futile, and total hip replacement, either acutely or delayed, might be the more realistic option.
Does delaying surgery affect the long-term outcome?
Yes, the delay to surgery significantly impacts outcomes, particularly for ORF. Prolonged delays beyond that optimal window, say more than 5 days for complex associated fractures, or perhaps more than 15 days for elementary fractures, have been consistently shown to negatively impact a surgeon's ability to achieve and maintain an anatomical reduction. This directly affects the long-term prognosis and increases the risk of secondary osteoarthritis developing later.
What are the most common long-term problems people face?
In terms of common long-term complications, post-traumatic arthritis is by far the most frequent issue, leading to chronic pain, stiffness, and functional limitation, often necessitating that late THA. Heterotopic ossification is also common, where that abnormal bone grows around the joint, physically restricting movement. A vascular necrosis, or AVN, of the femoral head occurs in roughly 6 to 7% of all acetabular fractures, but the risk is higher, perhaps up to 18%, in posterior fracture patterns or after dislocation, where the blood supply to the femoral head is most vulnerable. Other significant long-term issues include chronic pain, which can be multifactorial, and persistent nerve injury, such as that debilitating foot drop from sciatic nerve damage, which can require long-term bracing and significantly impact quality of life.
How long does recovery typically take?
The recovery timeline for these major injuries is extensive and requires considerable patience from both the patient and the clinical team. While it typically takes around 9 to 12 months for the acetabular fracture itself to completely heal radiologically, achieving the full restoration of mobility and function generally occurs somewhere within 6 to 12-month window post-injury, sometimes longer. It's really important to set realistic expectations for patients from the outset. Due to the complex nature of these injuries and the potential for these long-term complications, many patients, particularly those with more severe initial injuries or those who develop complications, may not fully return to their pre-injury activity levels or occupations. The ultimate goal then is always to maximize their functional outcome and quality of life within the limitations imposed by the injury itself. So summing that up, yes. In conclusion, whilst complications can certainly be anticipated with these severe injuries, timely intervention, meticulous surgical technique when indicated, and truly comprehensive post-operative care, including rigorous DVT prophylaxis, early but safe mobilization protocols, and vigilant pain management are absolutely crucial for mitigating adverse outcomes and improving the long-term prognosis. It's all about aiming for the best possible quality of life we can achieve for every individual patient facing this challenging injury.
Professor, that was an incredibly thorough and insightful review. You've distilled years of complex experience into truly digestible knowledge for us. Let's move into a quick lightning round now, just to crystallize some key insights for our listeners. First up, one essential piece of imaging you simply cannot go without for accurate acetabular fracture assessment.
Oh, definitely a high-quality CT scan with meticulous multiplanar reconstructions. It's non-negotiable for planning.
For managing our older patients with these fractures, what's a single core principle that really underpins your entire approach?
I'd say proactive multidisciplinary medical optimization combined with a tailored focus on early functional mobilization. Get them assessed, get them optimized, get them moving safely.
What's one common diagnostic or management pitfall that orthopedic professionals should always be wary of with these intricate injuries?
A common pitfall. Perhaps failing to thoroughly assess for and address marginal impaction of the articular surface. Or, relatedly, misinterpreting complex pelvic ring injuries that involve the acetabulum as solely acetabular fractures. Understanding the full extent of pelvic instability is key.
Finally, what's one quick win, if such a thing exists, for significantly reducing long-term complications after an acetabular fracture?
A quick win. Well, it's not always quick or easy, but achieving and rigorously maintaining an anatomical articular reduction, keeping that postoperative displacement under 2 millimeters, is undoubtedly the cornerstone of preventing or delaying post-traumatic arthritis. That's the goal.
This deep dive has truly illuminated the intricate world of acetabular fractures, offering critical insights for our medical professional audience. Let's just quickly recap some key takeaways to enhance your understanding and clinical practice. Firstly, a crucial understanding. Acetabular fractures are distinct, complex intra-articular injuries. Remember, even seemingly simple patterns like posterior wall fractures, often linked to dashboard injuries, can carry a surprisingly poor long-term prognosis due to associated issues like impaction or nerve injury. Precise early diagnosis is vital. Secondly, accurate diagnosis hinges not just on standard X-rays, but specifically on Judith views and critically detailed CT scans. These advanced images reveal subtle yet vital signs like the Gull sign or spur sign, which can entirely alter your treatment approach and the patient's prognosis. Thirdly, remember management is highly individualized. It spans from meticulous functional conservative care, emphasizing early mobilization, especially in the frail elderly, to complex surgery like ORAF or acute THA. The choice depends heavily on the patient's health, bone quality, fracture pattern, and, importantly, available surgical expertise. Fourthly, the long-term outlook and the ultimate survival of the native hip hinge significantly on factors like age, initial injury severity, and pattern, but most critically, the quality of articular reduction achieved. Diligent prevention and management of long-term complications like arthritis, HO, and AVN are paramount. And finally, never forget, an associated hip dislocation is a true surgical emergency. It demands urgent reduction, ideally within hours, to mitigate both immediate risks like AVN and long-term consequences for the patient. Our deep dive into acetabular fractures has been incredibly insightful today, really shedding light on the complexities and advancements in managing these challenging injuries. We truly trust this discussion provides you with valuable perspectives to inform your clinical practice and ultimately improve patient outcomes. If you found this conversation valuable, please do consider sharing this deep dive with your professional network on LinkedIn or perhaps on X. Your support helps us reach more colleagues who can benefit from these discussions. And if you haven't yet, please take just a moment to rate and review our show wherever you listen. It genuinely makes a difference in helping others find us. A profound thank you again for graciously sharing your expensive knowledge and experience with us today. It's been an absolute privilege.
Thank you again for having me. With my pleasure.
Until our next deep dive, continue to explore, question, and expand your expertise. Goodbye for now.